So that was interesting because we didn't share the slides, but it's very nice to see. That was a great introduction by Dr. Friedman and Dr. Teshpar. And I think I'm going to give the bigger picture, my insights of everything that has been going on around molecular classification. I will not limit myself in immunological. I will also touch a little bit upon genomics of colorectal cancer. So in my opinion, we are thinking about molecular markers and classification in three separate groups now. And until very recently, we only thought about cancer cells. But we have in the tumor, in addition, the immune cell and the stroma cell. And we have biomarkers for each of these compartments. It can be genomics, transcriptomics, proteomics. I'm going to give you some examples here in terms of tumor cell markers, RAS mutations, BRAF, HER2 amplification, and microsatellite instability. These are validated markers at the genomics level in cancer cells. But we have Immunoscore, proteomics marker for immune cell, and TGF-beta signatures, for example, for assessing the stromal cell compartment. In biomarker research, we always think about, is it predictive, prognostic, but it can also be diagnostic. So I will show you also, and Dr. Kopets later will give you some insights about ctDNA next-gen sequencing post-surgery. And it's all integrated. And as the previous speaking were telling, probably we need to use multiple markers to be really able to predict either response to therapy or survival. So precision medicine has been, in the past, very simplistic in colorectal cancer. Single gene, single marker, single drug. We are now living in a situation that we have multiple gene, multiple markers at the same time, and definitely combination of therapies, targeted therapies and immunotherapies. And in the future, there is no other way but to look broader with immune markers and adaptive. Probably look at this over time. At the time of diagnosis, later on at the time of progression when the patient becomes resistant to therapy. This is also playing a role. The original paradigm, single gene, single marker, single drug, you have some examples here. The response rate was less than 5%. So there is no more room to look at single markers in colorectal cancer. And what we did to understand the biology and to try to improve clinical endpoints was first look at the genomics level. And what we learned is that there is dynamics of target inhibition and dynamics of clonal selection. This is just one example with BRAF mutations that if you target upstream, there is parallel signaling activation, that you need multiple blockage in the pathway to have the response. Another example here with a RAS mutated as an emergence resistance mechanism when you have exposure to anti-EGFR therapies. It's clear that you are selecting the clones that are resistant. So at the end of the day, what we are only doing is forgetting a minor, very small, tiny subclones in the original tumor that will explain the resistance later on. So the genomics, all this learning led us into this new area where we have to look at multiple genes at the same time and do multiple targeted therapies, okay? And what we call a genomically stratified analysis, or also here you can see that you have to look at mutation C, combine two therapies, or mutation A plus B, and then combine another therapy. And here, adding circulating tumor DNA analysis, for example, at multiple time points to understand the best response. Okay? Here are three examples. A quadruple wild-type colorectal cancer, that is KRAS and RAS, BRAF, and PIK3CA wild-type. That will be the best candidate for anti-EGFR therapy. For BRAF, you need a triple combination to have the highest activity, and RBB2 amplification in the setting of a previous KRAS wild-type tumor, then a double hit of HER inhibition is required for having activity. Here we are seeing a response rate. That's a BRAF mutated example. with the triple combination, around 30%. And with the HER2 amplification with KRAS wild-type background, also this is trastuzumab plus lapatinib, 30% response rate. So we more or less reached a plateau, at least with the genomic markers that we know so far. It's obviously need to understand better how to predict response, and with novel field of immuno-oncology drugs, we need to understand the microenvironment dependencies, and this is where, again, transcriptomic and stromal immune classification start to play a role. So I will not go into the consensus molecular subtypes that you know, just to highlight there are clear differences in right versus left side in the distribution of the subtypes, and this may explain some of the associations and interactions that you see in the clinics. But we are now looking at colorectal cancer from a different perspective, a more multi-omics classification. You obviously has the MSI subgroup, the mutation, copy number count that have opposite directions, methylation. Here the four consensus molecular subtypes with different pathway activities. But this clearly matches to the stromal and immune microenvironment. So the MSI highly immunogenic, and the opposite direction, the immune tolerant, immune suppressive CMS4 subtypes. Okay, but I want to highlight one thing is that most of the gene expression signals really in colorectal cancer derive from microenvironment cells. So when we always talk about the CMSs and the immune classification, maybe we will have to change, as Dr. Teshpar was telling, maybe we'll have to change a little bit and look at gene expression from a different perspective, from a microenvironment perspective, to really understand the best prediction of response to immuno-oncology drugs. But it highly associates with the CMS 1, 2, 3s, and 4s. Okay, so that's a very clear-cut differences. You have one hypermutated, that's PD-1, PD-L1 dependent with cytotoxic T cells here, and the other with inflammation, colitis, TGF-beta in complement playing a major role, and all the immune suppressive cells together with stromal cells as the most relevant players in the microenvironment. The response to PD-1 blockade in MSI tumors is well known. The question is really how to translate this to an MSS population. And this is what brings us to this new future perspective around molecular subtyping in colorectal cancer and adaptive therapy. I will separate us this next 5 minutes and two groups. First, discuss a little bit about how I think in early stage colorectal cancer it may play a role, and then in metastatic with two examples, the right versus left side anti-EGFR interaction, and the future of immunotherapy combinations in colorectal cancer in light of the molecular classification. So early stage colorectal cancer, I think that is not a single marker with hazard ratios like dramatic as these. So ctDNA in stage 2 colon cancer, no adjuvant therapy, you see extremely or 100% chances of relapse if you have a positive test. The sensitivity is relatively low still, but if you have a positive test, this means relapse 100%. In locally advanced rectal cancer after chemo, radiotherapy, neoadjuvant, and surgery, again, 3 weeks after surgery, you'll measure circulating tumor DNA. That's a personalized test looking at particular mutation. That's a diagnostic test for minimal residual disease. So in early stage colon cancer, this will eventually come to clinics. This is early days still. We have a lot to learn, and Scott will talk about this later, but this is very clear. There is no other prognostic marker as strong as this in early stage. So the question so if you ctDNA positive, let's just give chemotherapy and we treat these patients. These are responsive to chemotherapy. I think that's another big mistake that we made in colorectal cancer. We know, this I'm just showing two Kaplan-Meier curves. These are patients treated with adjuvant chemotherapy, the oxaliplatin-based chemotherapy, the majority of them, and you see that even if you have the standard of care therapy, there is still 50% of chances of relapse if you have a mesenchymal, stromal-rich, immune-suppressive tumors. So that's a lot about the stroma and immune suppression that is telling about prognosis in early stage. And again, if you look at Immunoscore, immunoactivated, cytotoxic activated, when you have very high infiltration, you have a very low risk and more than 85, close to 90% of chances of having a good prognosis after standard of care therapy. So in the future, eventually we'll need to combine, because of the failures that we had with bevacizumab, for example, cetuximab in early stage, we'll eventually need to combine, again, maybe a diagnostic test here that you can really split the patients of having high versus low risk. And then if it's positive, it's not only giving chemotherapy that's going to change the survival curves. You need to add, again, on top of that, a tumor profiling to understand what is, according to the risk of relapse, a different match therapy that obviously includes immunotherapy, because immune blockade is for sure the most important marker or the most important drug to combine with standard of care therapy here. And particularly the ones that have the stromal-rich immunosuppressive microenvironment. Maybe for the epithelial immune desert microenvironment, you need to attract T cells to have the highest activity. So this is still hypothesis, but we have to think about combination of markers in early stage as well to probably optimize adjuvant therapy. And in the metastatic setting, I will give you an example for the cetuximab story and EGFR therapies. You see here progression-free survival in a RAS-BRAF wild-type population, the canonical CMS2 having the highest activity and no benefit, 2-month progression-free in the mesenchymal group. This has been shown to be the case also for a trial that had led to no approval. That's a combination of cetuximab plus bevacizumab as compared to bevacizumab alone. That's the CAIRO-2 trial. And you see, using an immunohistochemistry marker, that maybe there is one group, epithelial, CMS2s and 3s, that has activity of combination of cetuximab in the first-line setting. That's not the case for a more mesenchymal subtype. So again, within a genomically selected population, you might have differences in outcome according to that. And then going back to recent data from CLGB, that's the CMS1 versus 2 interaction that Dr. Teshpar was showing. The CMS1 MSI immune hypermutated having very poor outcome with cetuximab, and the CMS2s having the highest benefit in terms of overall survival when they give first-line cetuximab upfront. So these are the forest plots that you have already seen. Just to highlight the strong association in the CMS2s and the trend here for CMS2. So this brings me to the story of right versus left side of the column. I'm going to steal also slides from Dr. Copes from an ASCO presentation. This is RAS wild type colon cancer. You can see extreme enrichment of CMS1 in the right side of the colon. These tumors have less overexpression of EGFR, the ligands, more BRAF mutations, all other rare events, genomic events that may confer resistance to anti-EGFR, MSI, SIMP high, and these are the ones that we know have less of an activity from a anti-EGFR therapy, even if they are RAS wild type. And on the other side, the CMS2 clearly enriched in the left colon with overexpression of the receptor, the ligands, and less mutations and other events. So again, this is probably telling me that we still don't have a good marker, probably as good as the right versus left side of the column, but it's a lot of biology underlying these associations, and definitely at the transcriptomic level we can see some differences. And then to finalize, looking at immunotherapies. So this is a slide from Dr. Friedman's group showing a very nice potential strategy for immunotherapy in cancer based on a cytotoxic adaptive T cell infiltration or an inflammatory myeloid angiogenesis infiltration. If you have this high here, adaptive, and low inflammatory that's the anti-checkpoint therapy, favorable outcome. If you have on the other side the combination, the very high inflammatory, you might have also adaptive immunotherapy, immune activation high, but you definitely need a different approach. And here you definitely need to bring the immune cells to the microenvironment to have some activity. And these are just some examples. For the mesenchymal, we probably need combinations with TGF-beta, anti-angiogenic TKIs, and from the immune desert, you definitely need either to bring immune cells to the microenvironment, or also another strategy is to increase the antigen presentation, neoantigen presentation, and there are two therapies in investigation in combination with PD-1 blockade, epigenetic therapy, MEK inhibitors, for example, that may increase the expression of antigens and therefore bring immune cells to the microenvironment and have some activity. So this is just one example. That's PD-L1 blockade plus MEK inhibition in metastatic colorectal cancer. We are seeing responses here in MSS, non-hypermutated tumors, and one of the potential explanations is again immune infiltration secondary to antigen presentation, and with the SEA CD3 T-cell bispecific antibody combination with Atezolizumab in MSS colorectal cancer. That's the first time that also seeing not dramatic responses, but very long-lasting clinical benefit here, and even in some cases a major reduction in tumor size. We are at Vall d'Hebron in collaboration with many other European institutions running a clinical trial that's called the MoTriColor project. We do a gene expression based on FFPE upfront. That's the primary tumor tissue. We are treating metastatic patients, but we are looking at the primary tissue here, and according to different signatures, one TGF-beta, we give a TGF-beta inhibitor, combination with chemo. If it's MSI-like hypermutated, you give combos with PD-L1 inhibitors, and this is trying to bring, again, gene expression to from paraffin tissues as close as possible to clinics to see if there is any added value. Now, what is happening, we have classifiers for the clinical lab. Not anyone can ask, but definitely they are being optimized for that. At this moment, no, you cannot go back home and ask for a CMS classification, but definitely in the near future it will be much more easier, and it's already available for retrospective analysis, as Dr. Teshpar was telling. Many clinical trials and looking for interactions, and there is a large number of investigators looking at primary versus metastasis heterogeneity, and this is an important question to answer. And in the future, definitely we will be stratifying clinical trials, particularly immuno-oncology drugs combinations based on the intrinsic transcriptomic classification. So my take-home message is that for prediction, that is still unknown what is the best combination of molecular markers, and again, it's a driver gene plus MSI gene, protein expression, pathway activation, but it's definitely a combination of the markers that will be predictive of response to bevacizumab, for example. And we need examples here. In the adjuvant therapy, definitely ctDNA analysis may play a role, and with targeted immuno-oncology drugs, we definitely need to combine transcriptomic analysis to have a clear understanding of the responses. Thank you very much for the opportunity to talk, and this is my group. I want to highlight the help from people at Vall d'Hebron and at Sage Networks. Thank you very much.